Good evening. Welcome
Good evening, everyone.
2000.
Oh, go ahead. Good evening, everybody. Today we're...
Go ahead, Dr. Grabowski.
Sorry. Good evening, everyone. Tonight we're going to talk about a condition that I think every one of us either has a relative that has this condition or we know somebody that has this condition or, of course, dementia. And I think you're going to find by the end of this evening there are a lot of nutrients that you may not have thought about when you are looking at this particular disease and things that we can really do to help slow down or prevent the acceleration of this particular condition. And I think that's the big key about this is, you know, this is one of those degenerative diseases that is accelerating at a very fast rate. And I think you're going to see that when we get into the situation of talking about some of these statistics. Because when we look at this particular condition, that once again, we have to, excuse me for a second, but I'm having trouble forwarding this. All right, sorry about that. There's a little technical difficulty we had there. That, as I mentioned earlier, that this is a condition that I think every one of us either has a relative that is suffering with this condition or we have a friend that has a parent or relative that's also suffering with this particular condition. And I think that you'll see by the end of this evening that there are a lot of nutrients that we have to consider when we are looking at this particular disease in regards to decreasing the acceleration and the percentage of people out there that are suffering with this. As you know, once this particular condition starts, we cannot reverse the damage that has been done to the brain, but once again, we can definitely slow down the process, and I think that's the main thing that we have to consider at this point is how important that is. So you can see here that on a worldwide basis, this is a major concern because it is accelerating, and some countries have a faster rate than others. And even in the United States, some states have a higher rate than others in regards to what the percentage is going to be in the next 5 to 10 to 15 years. And I think that's very interesting when we look at it from a United States tendency is how some states differ than others. And if we look at it for that reason, that it's important to think, is there something that's present in those particular states, whether it is a certain food type or the lack of food intake that we are actually seeing in that particular area of the United States that's having a higher tendency for acceleration of this disease. As you can see here from the first bullet, that 1 in 9 people aged 65 and older has Alzheimer's. In fact, one of the other statistics that people talk about when we talk about Alzheimer's is at the present rate, we have a new case of Alzheimer's every 66 seconds. And some epidemiologists estimate that by year 2040 or 2050, that it may be one every 33 seconds. And the good thing about it is that we have found out about certain dietary habits and nutritional deficiencies that may play a major role. The point is we can't just rely on one or two nutrients to decrease this acceleration. And that's what I think is so important, that we look at multiple nutrients when we are trying to affect this particular disease. As you can see here, when we talk about cognitive dysfunction, of course, we talk about the MCI, or mild cognitive impairment, how it goes to dementia, and then, of course, eventually dementia may go into the full-blown Alzheimer's. And you can see here that there's a large percentage of people that have this particular condition, the mild cognitive impairment, that eventually goes into dementia. And in a very short period of time, as you can see, within about 5-year time span. The other thing that's important is when we are talking to patients about this particular condition, they say, well, yeah, I think I'm kind of losing my memory a little bit, or I'm having more difficulty remembering things, is that may be, once again, the early indication of the MCI or eventually going into dementia. Now, I can't more or less go into the detail of all of this because of time, but some of the new things that we're looking at, in fact, they're doing MRIs of brains and seeing if certain parts of the brain, once again, have atrophied, or if there's blood flow changes and things like that, that are giving us some indication on whether or not these people may eventually go into the Alzheimer's status. So, as you can see here, from a pathological standpoint, these are some of the things that occur with dementia. And some of these same things are happening as we get into the Alzheimer's type of situation. And one of the things that, of course, we look at is the beta amyloid plaques. Everybody talks about this particular presentation or pathology finding. And then now we're talking about also the brain atrophy. And I think you'll see some of the things that we can do on a daily basis or weekly basis may actually slow these processes down that are very simple to more or less resolve. And we have to get people out there and get them exercising, because that's one of the things we have found, that exercise may actually decrease the acceleration from dementia to Alzheimer's. Now, one of the things that usually comes up in the topic of Alzheimer's, if you read all the literature out there today, are the B vitamins. And you'll see some of the roles with the B vitamins and how they may play a large part. But once again, for those of you that have been in practice for a while and have been practicing nutritional implementation, I think it's very important that you realize that we have to look at these in a very global means. And what I mean by that is we can't just assume that it's folate or B12 or riboflavin or B6, that we look at these as a group. And, of course, there is a lot of information out there about the MTHFR, and a lot of people today have studied this and have shown how this plays a major role in a lot of pathologies. It's not just, of course, the OB/GYN field. It's not just the neurological field. I mean, we see it in cardiology. We see it in autoimmune diseases. I mean, several different types of diseases. So the MTHFR is a test that I think is very applicable if you are trying to evaluate and treat the individuals that have, whether it's MCI or dementia or Alzheimer's, because it's going to be complemented, once again, by the micronutrient test. Now, what happens sometimes is I have patients come into my office and they have been to another clinician and they have had an MTHFR done, and that's it. They haven't had any other type of testing, and they've put on Deflin or they've put on a high dose of B12, and that's it. They haven't been evaluated for any other B vitamin than those two. So once again, this is what I'm emphasizing to you, that it's very important that we look at the B vitamins as a global presentation and we address them as a group, but specifically which one may be deficient with each of our patients, because we know we all have a different biochemical makeup and we have to address it from that standpoint. And once again, I think you will see that as we go further into this webinar this evening on how this plays a role and why we need to look at so many different nutrients with this condition. So once again, you can see that Alzheimer's is the most frequent type of dementia. It, once again, is costing us a lot of money. Excuse me. And so as a result, if we're looking at cost containment in the healthcare field, this is definitely one that we want to address. And I think you can see that there's enough evidence out there to show why we need to implement nutritional intervention. A lot of the medications today used for treating people with dementia or Alzheimer's, as we know, won't reverse the condition, just like nutrition can't repair the brain damage that's been done. But once again, what's causing this condition to occur? And one of the common topics is, of course, inflammation. And I think you'll see how other systems play a role with the inflammatory process and eventually come into play with the neurological condition. So when we are looking at this further, once again, look at this with, as we increase in our age, you'll see based on the various literature out there that if you're greater than or equal to 65 years of age, that you have somewhere between 5 and 8% chance of getting Alzheimer's. If you are greater than or equal to 75, then it's 15 to 20%. Excuse me. And if you're greater than or equal to 85, that you're somewhere between 25 and 50% chance of having this condition. The point that's important about this is we're finding out that there's actually indication now that this brain damage or problems that we're finding in 65, 75, and 85 years of age can begin as early as the late 30s and early 40s. So it's not something that we should wait and say, well, let me see how I am when I'm 65, that we have to start attacking this from a nutritional standpoint or lifestyle standpoint to really decrease our chances of having this occur. And I'm saying this in a facetious way, but I tell some of my patients is we don't want to retire and forget why we retired. And all of you patients out there work very hard to earn a good living and to provide for their children and hopefully get to the point where they retire, and as a result, they have problems like this occurring, that they hit 65 or 75 years of age, they want to retire, and once again, now they're having memory issues. They're having this cognitive dysfunction, and they work so hard all these years to get to this point in their life, and now they have issues. So I think it's very important to emphasize to our patients in this aspect that this is something that is growing at a very fast rate. As I mentioned, it could double maybe in the next 20 to 30 years if we don't do something right now from a preventative standpoint. And we talk about several other degenerative diseases like heart disease and osteoporosis and diabetes and so on. But once again, and I'm not downplaying those pathologies by any means, but once again, I think all of us that have parents that may be still living or relatives that are still living that are in this age range of 65 to 85, and we've seen them mentally decrease, that it's very difficult for us to watch that. And there's, once again, some literature out there showing that approximately 1/3 of the caregivers of these individuals actually go on antidepressants. So it's very taxing to not just the member or the patient themselves, but the family members on how much stress that's placed on them to take care of these individuals. So taking that into consideration, as I mentioned earlier, one of the things that we look at is this whole amyloid peptide presentation, the neurofibril tangles, and how they're developing and why they're developing. So once again, another thing that we look at, and this is where some of the People out there are doing MRIs of the brain and seeing this actual atrophy occurring. And this is where we're going to see how some of the literature from the nutritional standpoint are actually supporting this, is how some of the things out there that we can do nutritionally may decrease this atrophy occurring. Getting these people out there to exercise will also encourage that. So once again, it's not just a dietary aspect, it's also an activity aspect as well. However, when we look at this particular disease, there's some very strong modifiable risk factors that we know right now, and this may increase over the next few years as far as research and what other strong modifiable risk factors are, but we know for sure that people that are diabetic, people that have high blood pressure, people that are overweight, people that smoke or have smoked, people that have signs of depression, once again, the cognitive inactivity, and of course, their low educational attainment. So those are 7 major factors that we should be looking at. And when we take a history from individuals, is go back into their history. Not just their last year, their last 5 years, but did they smoke 20 years ago? Have they recently quit, or are they continuing smoking? Do they have any family history of diabetes? They may not have diabetes right now, but do they have a strong family history of diabetes? And do we think that they may develop diabetes over the next 10, 15, 20 years, which once again may put them into a higher risk for this particular condition? So it's very important to look at these and note these, and once again emphasize to the patient that we're not just talking about your diabetic status, that we're talking about your diabetic status highly affecting a strong neurological disease like Alzheimer's and increasing your risk of getting that. So taking that into consideration, one of the nutrients that has been showing some strong association with Alzheimer's is vitamin E. And of course, one of the main roles of vitamin E is having an antioxidant potential. And inflammation, anytime we have inflammation, we know there's more free radicals, and we know we need more antioxidants. What's interesting about this also, though, is how many people do not meet the basic daily requirement for vitamin E, as well as some of these other nutrients that we're going to talk about. And the thing that's very interesting, I think, about this, and we all have to look at this if we've been in practice for a while, and for those of you that are new to nutrition in regards to your practice, is a lot of the information that we're getting in regards to actual intake is based off some very old databases. A lot of them 1989, 1990 databases in regards to nutrient content of foods. And we know that the food back then in the 80s isn't the same as it is now in 2017. So if we're looking at some of this information going back or even going forward, are we really truly evaluating the adequate amount of the person's intake based off of old databases? So this may be even less than what's shown on this screen and some of the other information that I'm going to show you. The point is, we have to have some objective means of determining if a person is actually low in these, rather than just looking at a database, plugging in their dietary habits. Because once again, think about this. How are these patients really measuring a half a cup of this or 2 ounces of this? They're giving you estimations. We're taking those estimations, we're pushing them into a computer program and say, oh, by the way, your dietary habits show this, this, and this. But we're not doing anything from a laboratory standpoint that's really giving us true findings of what's happening. And that's where, once again, the spectral cell testing comes into play, that we are looking at the actual function of these nutrients and whether or not they're doing their job, and it's a biochemical individuality that we're looking at from one patient to another. And that's, once again, so important. So you can see here that vitamin E deficiency has been shown to be associated with several chronic diseases. Tonight, of course, we're talking about Alzheimer's, but you can see diabetes and cancer and cardiovascular disease. And so it's very common to have some of these other conditions and also being affected by vitamin E. And this is why we have to look at these other conditions and a family history or a person's past and present medical history to determine if they're more prone to this particular deficiency. And we'll talk about different forms as well. You can see here in a study of 2010, a Swedish study, actually showed that the octogenarians actually had a reduced incidence of AD when the patients had, or these individuals had higher plasma levels of total tocopherols, tocotrienols, and of course overall total vitamin E. This was published, you can see, in the Journal of Alzheimer's Disease in 2010. What's really important about this slide is not just vitamin E, but if you notice, they talk about tocopherols and tocotrienols, and they talk about total tocopherols as well as tocotrienols. So what we're saying is it's not just the alpha tocopherol that's important, but the beta, the delta, the gamma, all of those are very important to be evaluating and consuming. And this is why it's important that we look at this when we are trying to supplement patients and trying to correct a particular vitamin E deficiency. That we look at all of these different tocotrienols and tocopherols to assist these individuals. But once again, very nice study that was done that showed this particular relationship. Vitamin D. We all know in the United States that this is a major problem. It's a major problem in the world as well. That there's a high incidence, depending upon who you read, and what statistics, once again, you're looking at, but somewhere between 65 and 85% of the population may be low in vitamin D. Now, most of the literature talks about serum levels, and you can see here that, once again, according to the Endocrine Society, a deficiency of vitamin D, once again, as a serum level, is below 20 nanograms per milliliter. An insufficient amount is between 21 and 29 or less than 30. However, the question is, this is a static, more or less, evaluation. Is it functional? Is the person actually utilizing the vitamin D intracellularly and getting the full benefit? So that's something else that I think is coming down the road, is we're looking at different tissue compartments and really seeing if vitamin D status or utilization is there. Now, one of the concerns is, can you take too much vitamin D? That's always a question from our patients. You get it, I get it in the office as far as, can you give me too much of this product? What's going to happen if you give me too much? And this is some of the information out there based on a New England Journal of Medicine article that when you get greater than 150 nanograms per milliliter. There is some other information out there that if you go above 100 nanograms per milliliter, that there is some question on whether or not there might be some cardiac involvement. My point is that, once again, we know we have to be above 30. A lot of people out there say now we should be between 50 and 70, and some even as high as 80. But no one, as far as I know right now, as a general rule, is advocating greater than 100. So it's very important that we try to get them at least to the 50 level, I think, or somewhere between 50 and 70 nanograms when we were talking about serum levels. Now, look at this. This is more or less on a worldwide basis that they estimate 1 billion people suffer from either a vitamin D or, as far as deficiency or insufficiency status. And I think that's very important. So if we are really going to attack one of the major diseases, which we're talking about tonight, Alzheimer's, this is one nutrient for sure that we have to address. And the level is, once again, is 30 enough? Do we have to really look at 50? Do we have to look at 70 nanograms? Or, once again, looking at an actual function of this particular nutrient? And I think that's where we're really going in the future, is what is the function of our nutrients inside the cell rather than looking out in a different compartment like the serum or plasma and really determine where the patient is. Now, here's some more information and talks about some of the proposed relationships of vitamin D and how it may increase the risk of dementia or Alzheimer's. Showing you, once again, we know there's some genomic type of relationships that people may have abnormal vitamin D receptors. We know that, once again, minerals like calcium are highly related to this. The transmission, the vascularity, of course, you can see the amyloid beta and tau accumulation. Of course, another thing that we talk about is antioxidant status and oxidative stress. And vitamin D now is, once again, considered by a lot of people as having antioxidant potential. And, of course, also having the ability to decrease the inflammation. So some of the well-known mechanisms that are causing dementia or Alzheimer's are definitely related to this nutrient. And I think it's so important to continue looking at that. And once again, this may be going back to what I mentioned earlier about different regions of the United States, different regions of the world, is are we going to eventually see some correlation like that, just like we do in, say, situations like multiple sclerosis, that we start to see certain regions around the world that are highly associated with MS and other pathologies. Now, one of the things that all of us are probably well familiar with is the immune relationship with vitamin D. And here you can see we talked about inflammation and Alzheimer's. And vitamin D, as you can see, has several different functions. And certain products like tumor necrosis factor alpha and interleukin-4 and interleukin-1 beta. So there's a lot of different markers that people have looked at this disease or other diseases that involve these particular inflammatory cytokines that have been shown to be modulated, once again, with this particular nutrient. And I'll show you later on why it's so important to look at a large amount of nutrients, because they interplay with one another. And that's the difficult thing to really understand or get across sometimes to patients, is they think, oh, this one nutrient only does this, and it's not dependent upon other nutrients. And we all know in the healthcare field that there's so much nutrient-nutrient interactions. There's a lot of nutrient-drug interactions and so on. And so it's important that we look at all these. For example, I've seen this in my practice for numerous years. People taking large dosages of vitamin D and causing some decreased levels of the other fat-soluble nutrients. And there's some competition there. So as we maybe increase the intake of vitamin D to stop some of these mechanisms that may lead us down the road to Alzheimer's, are we causing some other deficiencies like vitamin E, which I just recently talked about, that can also predispose us to Alzheimer's? And that's why we need some objective means to really say, yes, these are all in balance. This large dose of vitamin D did or did not cause any other fat-soluble nutrient abnormalities, and monitor this on a regular basis. And that's the whole point of the webinar today, is not only recognizing nutrients that play a role, but balance of nutrients that come into play and how they're so interrelated. Now, one of the other topics in relationships with vitamin D is nitric oxide. And you can see here that we've shown that higher levels of nitric oxide may cause cell death, once again, through various mechanisms. And this could be, once again, controlled or somewhat modulated through vitamin D. So it's very important to take into consideration these different mechanisms. And as we go down through research and start to hear some of these things, that how these nutrients can play a role. And that will, of course, stimulate other researchers out there to maybe grab a particular nutrient and do more testing to see how strong of impact that nutrient or various nutrients may have on this disease, just like others. As we talked about earlier, the relationship of calcium and vitamin D. So here we go, nutrient-nutrient connections. Not necessarily interaction from a bad standpoint, but a good standpoint as far as a complementary. So if a person's low in calcium, they may be low because of vitamin D. And we know that vitamin D enhances calcium uptake. So once again, people may out there be taking vitamin D, but they may also have a low calcium intake, and this may play a role as well. So I think it's very important to keep this in mind that we have to evaluate these complementary nutrients, just like I mentioned earlier about the B vitamins. We don't want to just look at folic acid or folate and B12. We have to look at all the B vitamins and how they play a major role. Vitamin A, not talked about much in regards to dementia and Alzheimer's if you are out there practicing, unless you really have got into the literature, but it is an important nutrient, and for several reasons. One, it's very important for the immune system. It does have an effect with neurotransmitter release. We know that, once again, the neural differentiation, development, and all that is very dependent upon vitamin A. And a lot of people are nervous about this nutrient because of the talk about toxicity. And it's like when I used to teach at various institutions, and I used to tell them the big thing about any nutrient, I don't care if it's a B vitamin or a fat-soluble nutrient, is monitor your patient. It's just like a patient taking a medication, and you monitor the side effects, or you monitor that particular drug in the blood, or what it's trying to do. For example, a statin. That if a person's taking a statin, you're monitoring cholesterol to see if that cholesterol is getting lowered, and is it getting too low. And then you're also monitoring some other systems like the musculoskeletal system and seeing if it's having any impact with that. Does the person have muscle pain? Are there certain enzymes like CK enzymes that are elevated with the statin medication? But my point is this, is you have to monitor the patient for all of these. And these, as you notice, the first three nutrients, or the last three nutrients, I should say, that we talked about here, they're all fat-soluble. And not too many people talk about vitamin E toxicity, even though there is some literature out there and it can happen. The big thing is how does a large dose of vitamin E maybe affect vitamin D status and vitamin A status, because they are, once again, fat-soluble. So it's very important to keep in mind all of these nutrients, especially also the age of the individual when you're talking about these nutrients. Now, you can see, based on some of the citations here, back in the late 90s, they've noticed some correlation with cognitive function or performance with the beta-carotene. They were looking, once again, at serum and plasma levels, so this is very important. And one of the things that you want to keep in mind, and think about this when you're dealing with your thyroid patients, thyroid hormone is very important from taking a beta-carotene or the carotenoids and, once again, going into the vitamin A status. And if people have this particular pathology, they may have an increased chance of vitamin A deficiency. So we're looking at a pathology that could affect a particular nutrient based on the hormone function of that particular organ, having a direct effect on conversion of one nutrient to another form. And I think that's very, very important to keep in mind. And we often hear this sometimes, especially if you deal with a lot of thyroid patients, is they might say, oh, they feel like they're brain fog, or they haven't been able to remember as well as others or in the past, and they wonder if their thyroid function is causing that, if there's something else causing it. It could be caused by, once again, the thyroid dysfunction itself, that hormone, but also the effect that it has on nutritional status, because they definitely are related in this aspect. And this is the only nutrient that's connected with it, but once again, has a significant role with the thyroid. Now, when we talk about vitamin K, I think most people, when they hear vitamin K, they think about clotting, they think about cardiovascular disease, and a lot of people now are aware that vitamin K has a huge role with skeletal integrity. that we know that vitamin K deficiency definitely can cause osteopenia/osteoporosis. But we also know that vitamin K has other roles in the body. These are some major sources of vitamin K2 besides these particular sources that are listed here can be produced by our normal flora. And I think that's very important to keep in mind because we will talk about that a little bit here in a few minutes on how our flora integrity may actually play a role with the brain. For those of you that are well versed in this field, you know that there's evidence that normal flora and intestinal integrity can cause, if it's abnormal, can cause depression, anxiety. We've seen it affect people that have ADD. We've seen various, insomnia, several neurological conditions. And so once again, this is another nutrient we're looking at. So if someone has an abnormal GI tract in regards to the makeup of the flora, that we could potentially be affecting this particular nutrient, and it could be playing a role, once again, with Alzheimer's or other neurological conditions. So you can see here that here are some of the functions or relationships of vitamin K in the nervous system. You can see everything from regulating the activity of proteins and the growth and development, myelination. A lot of people are unaware that it does have some role with myelination. Of course, mitogenesis, the chemotaxis, and of course, neuroprotection. So here's a nutrient that I think a lot of people, as I mentioned earlier, yes, recognize that this was important for clotting, but 20 years ago or 30 years ago, who would have thought that vitamin K would be considered with the central nervous system? And once again, I want to thank the researchers out there for looking at things like this and continuously finding some connections with this nutrient and other nutrients with some of the major pathologies today. Magnesium. This is one that is talked about, I think, in almost every system in the body. And I always tell my patients this: if there's one nutrient, and only one nutrient that I could carry in my office, this would be the nutrient. Everything from skeletal system to neurological to GI to biliary, I mean, you name it, that this particular mineral has a huge impact on our health. And it's highly affected by a thing that happens to us every week when we are under stress. When we are under stress, whether it's physical stress or psychological stress, we affect magnesium. And what's interesting is this just happened this past week in my office, that I had several patients come in and they have to fill out this detailed questionnaire before the first visit. And several of these patients this week came in and said, "Oh yeah, my eye twitches all the time, or my my facial muscles twitch all the time." That's a classic sign of magnesium deficiency. And of course, one of the first questions I ask is, are you under stress? Oh yeah, my job's very stressful, my home life's very stressful, or I exercise real heavily. Whatever the case is, we know magnesium is being affected. And you can see here, besides that common problem that all of us face every week or every month as far as stress, now, not only that is a problem, but we're not even consuming the recommended daily allowance on a large portion of people in the United States of this mineral. So we're low in this particular mineral, and then we have something we face every week or month that affects this. That's not including medications that are affecting this. That's not including food choices like caffeine that are affecting this. We're talking about intake, stress, and then we add all those other things to affect this particular nutrient. So once again, it has a huge role with inflammation and decreasing the inflammatory process. Here's another nutrient. We're finding here that you can see, we all know that vitamin C works as an antioxidant. We have shown, or I should say researchers shown in this particular journal, that vitamin C deficiency plays a very strong role in accelerated amyloid pathogenesis, which of course is one of the main findings of Alzheimer's disease. So once again, here is a condition that you can see in just a few slides I've shown you. The fat-soluble nutrients are involved. The B vitamins are involved. Vitamin C is involved. And we're going to continue with some other nutrients per se and some other tests to show you why we want to continuously look at a large amount of nutrients and see which ones specifically may push this patient of ours into dementia and or Alzheimer's. This is why I think it's very important to keep this in mind when you're reading a good scientific article on nutrition, is are these researchers looking at all these nutrients as a group, or are they limiting one or two nutrients? And the reason I say that is, of course, we always, as researchers, we're always trying to limit the variables. But in nutrition, it's so difficult because so many of these are intertwined with one another. And so when we look at vitamin D, are we looking at vitamin E? Are we looking at vitamin E, vitamin K, and so on? Just like vitamin C, or are we looking at just one B vitamin to have a role? Now, we know even with one or two nutrients, we find this true, in this case, with vitamin C as far as affecting the brain. But what about these other nutrients that we aren't looking at when people do vitamin C research or vitamin E research? And they say, well, only 20% or 40% of these people really had signs or symptoms of dementia or Alzheimer's. Well, that's because you only looked at one nutrient with that individual. Did you check and see other nutrients that may play a role with this particular individual? So going back to magnesium, because I wanted to show you in this particular case that there is a relationship here, is magnesium has an antioxidant capability. It's anti-inflammatory in nature. It definitely affects the inflammatory eicosanoids. So once again, we know that can occur. The reason why I showed vitamin C in between these slides is because one thing that we find with stress is often when patients are under stress, physical stress or psychological stress, they have magnesium deficiencies and they often have vitamin C deficiencies. Now, this isn't even taking into consideration Alzheimer's at this point. I'm just telling you from large amount of data that I've seen in my office that when people are under those types of situations, psychological or physical stress, that they have these deficiencies. You can see in this particular slide, they looked at serum ionized magnesium. Now, a lot of times when people are trained in the healthcare field, they look at the serum levels. And, of course, if the serum levels are fine, they think everything's fine. If you look at the bottom portion of the slide, you will see that they showed no significant differences existing between the two groups with respect to serum magnesium concentration. If you go back in the literature, back in the 80s and 90s, it clearly states, and even more current literature, that serum magnesium is not a very sensitive marker for magnesium status. Okay? I think that's very important to keep in mind. Now, let's talk about genetic testing. And I know, once again, I'm limited to time, but I think it's very important to point this out. There's various panels or testing capabilities of SpectraCell, and one of the things that they can definitely look at is ApoE. And there's some very strong evidence, of course, of ApoE and relationship to Alzheimer's. And you can see here that if you have, once again, the E4 form of this particular gene, that you are more prone to Alzheimer's. Now you can see the various percentages listed here in the U.S. population. And once again, you can see some are very low. The E4 are about 2%. The E2, E4 is about 2%. But you look at the E3, E4, there's 23%. So once again, those people are more prone to having this particular condition down the road. And you say, well, we can't change genetics. We can't change genetics. But can we do anything about it? Or does this genetic marker have an effect on us? And it absolutely does. Now, one of the other nutrients that's talked about out there in protection or decrease in the development of dementia or Alzheimer's, or I showed you earlier that depression, people that have depression have a higher incidence of Alzheimer's and dementia, is we talk about the omega-3s. And here DHA has shown to have some role with, once again, Alzheimer's. The important point about this is that The ApoE also, if you have this particular mutation or defect as far as genetically, you also may have a difficult time with DHA. As you can see here, people that have the E4 allele and the lower CSF8 beta 42 levels have been shown or associated with less transport of DHA to the cerebrospinal fluid. So once again, if DHA is somewhat protective of this tissue and we have a genetic defect that may, once again, or makeup I should say, that may put us into this compromised position, then we may have to give higher dosages of DHA to make up for that. The question is, how do you know what dosage a patient should, once again, take? You need some objective data. And once again, SpectraCell has a testing procedure. It's called the Omega Check that actually checks the DHA level of the individual. So once again, this is an objective way of determining the DHA. Now, when we talk about diets, there's a lot of diets out there, and some people say it's a ketogenic diet, and some people say the gluten-free diet, and others paleo diet, and so on. There's a diet actually called the MIND diet. And it stands for Mediterranean, once again, it's DASH intervention for neurodegenerative delay. And it's a modification, really, of these two types of diets. The DASH diet, as you know, has been highly used or implemented for blood pressure, for hypertension. Mediterranean diet has been shown to be very beneficial for cardiovascular disease, osteoporosis prevention, diabetes. Some even say it's very protective against cancers, and so on. So it's a very well-respected and known diet that's been really investigated. So here's a combination of this. And so it's very important to keep that into consideration. Now, some of the foods that we have found to be very important, of course, are the green leafy vegetables. Other vegetables as well have been shown to be very important. The berries as a group, but blueberries seem to have a very high importance in this particular group of fruit. And, of course, seafood as well, primarily, of course, the omega-3 containing seafood. So, once again, trying to get the DHA into the individual. So, it's not just about supplementation, but it's also dietary changes as well, I think, that are very, very important. Now, this is a very interesting finding, I think, that we talk about fructooligosaccharides and how these may actually affect the brain, but how may they affect other systems as well. So you can see here that FOS has shown to improve plasma ascorbic acid levels, but they've also seen that these particular products could possibly decrease the development of Alzheimer's from an antioxidant effect. So here's a good example how GI implementation or products that we may be taking, our probiotics with, of course, these particular items as well, how they may complement or decrease this. And we know how, once again, the GI tract comes into play with depression, anxiety, and some of the other conditions that I mentioned earlier. Mitochondrial pharmaceutics, once again, people talk about that all the time, is whether it's Alzheimer's, dementia, migraine, headaches. We know that mitochondrial dysfunction is very, very important. We know that, of course, oxidative stress. So, once again, anything that supports the mitochondrial portion of the body and the cells, I think, is extremely important. And this, once again, has recently been published in 2015. So when we look at the antioxidants, we can't, once again, just look at CoQ10. We can't just look at alpha lipoic acid or vitamin E or vitamin A. As you can see from the previous slides, there's several nutrients that have antioxidant qualities, and we have to consider all of those. And not all of those, or all the same ones, are going to be deficient in every individual. There may be some common findings, but once again, from one patient to another, there's going to be some individuality, and that's what we really have to note. And are they taking some medications that may be affecting these? For example, the CoQ10. Are they taking a statin that's causing CoQ10 compromise? Are they taking large doses of vitamin D that may affect vitamin E or vice versa? So, once again, we need some objective way of monitoring. Going back to, once again, the DHA and the relationship is showing some possibility of not only with dementia, but early signs, as we know, of mild cognitive impairment. So implementing this right away. And you can see here showing that DHA supplementation of 2 grams per day for 12 months in these MCI subjects had some effect on their cognitive function. And this, once again, may also affect their hippocampal atrophy or the potential for that. So dosing is important. But once again, even though we could give maybe 50 people 2 grams a day, and all 50 people aren't going to respond the same. So we need some other means of saying, yes, this is the right dosage for you, or we have to increase the dosage to really determine if that's going to be adequate for you. Then, of course, cardiorespiratory fitness. We're now finding out, and this is being supported, that when people exercise, that this may actually have a beneficial effect. It may actually decrease the tendency towards Alzheimer's. They've seen it more in elderly men than women, but once again, it's something to consider. I think you're going to see more and more research on physical activity and how it may preserve the brain, and the level is how much is good and how much is too much. Because once again, there are some things that we show that when people exercise real heavily, they do produce more free radicals, and may possibly increase their chances down the road. Now, I think, of course, Benjamin Franklin said it the best. And we all know this quote, but today is a good example on when it really is applicable, that we have to go after prevention, because we know once these things develop, once the brain damage is there from various means, whether it's from inflammation or lack of a particular nutrient or whatever the case is, maybe from smoking or maybe from, once again, alcohol usage, whatever the case is, we know that it's very important to look at this from a prevention standpoint, and let's hope that we can decrease the tendency from 1 every 66 seconds to what is proposed as 1 every 33 seconds in the next 20 to 25 years. So I'm going to answer some of the questions that some of you have submitted, and hopefully, once again, can put this in a better light. So one of the questions is, research now shows that the brain makes insulin. Do you think that insulin can prevent or slow down the progression of disease? I think it's very important to look at it from this standpoint, is that insulin plays a major role in several conditions. We know that insulin resistance has been talked about with cancers. We know it's been talked about with cardiovascular disease and so on. The point is this: not only is insulin production important, but what's really important is the insulin receptors. Is you can have the adequate amount of insulin. And we know this in type 2 diabetes. The people that have type 2 diabetes, for the most part, it's what we call insulin resistance. And so they're making the insulin, they have the capability of making insulin, but are they utilizing that insulin properly? And that's where like magnesium and zinc and chromium and alpha-lipoic acid and several of these other nutrients make a major role. And so I think, yes, we have to look at insulin, but we also have to look at, is insulin being efficiently used via insulin receptors? Which form of magnesium is effective for AD? Well, when you look at the bioavailability of various nutrients, and I'm going to talk about magnesium because that's what the question was, is magnesium glycinate has a very strong support for one of the highest bioavailabilities. There's other forms, of course, malate out there and citrate and so on. The thing that you have to consider is a lot of these forms are affected by products and foods like phytates and oxalates. And so a person may take a particular form, for example, magnesium citrate, but that form has a very high tendency to be locked up or affected, or the bioavailability is affected by oxalates and phytates. So here a person is consuming a lot of high oxalate foods that may have high amounts of antioxidants in them, but are also locking up that particular mineral or other minerals. So how do we know if it's doing that? Because a lot of times we'll look at a person's diet and say, oh, yeah, you eat very healthy. Well, but are they actually breaking out those micronutrients from that food and utilizing them. How do we know? Once again, we need some objective way of determining that. That's where the micronutrient test comes into play, and you say, yes, your diet that's high in magnesium is doing this, or yes, this dosage of magnesium that I'm giving you is doing that. The oxides, the gluconates, they have a much higher tendency to be malabsorbed or have a lower bioavailability than the malates and the glycinates, and that's true. And there's a book out there I highly recommend that you consider purchasing. It's called Amino Acid Chelation in Human and Animal Studies. It's published by CRC Press. It came out in 2012. And the author of that book does a very good job on taking you through the biochemical and the physiological functions and usage of minerals, and why the amino acids and the amino acid chelation process is so vital to us. Okay, one of the questions is, why would serum vitamin D be 70 if the vitamin D is deficient in the micronutrient test? As you know, well, for those of you that may not be familiar with the micronutrient test, the micronutrient test uses the lymphocyte as the cell of choice, and it's an intracellular test. The analogy that I use to my patients is this. Using a car, the gas tank would be like serum vitamin D. The fuel filter is, say, the cell membrane, and the engine is intracellular. You can have a full tank of gas, but if that gas is not getting through that fuel filter, is not getting through that cell membrane into the engine, who cares how much gas you have? You want the nutrient inside the cell. That's where the biochemical functions occur. If you think about your chemistry, you know, your glycolysis, your beta oxidation, your Krebs cycle, all of those things occur inside the cell. And when Dr. Shive developed this testing technology, that's why they looked at it as a functional intracellular analysis. That's what it used to be called. He was looking at the function of the cell. We have to make sure the nutrients get in. So once again, is your vitamin D not getting into the cell? It's out there in the serum, but if it's not getting into the cell, it's not functional. And that's why sometimes that can occur. Sometimes we find it might be cell membrane integrity. A lot of times we see oleic acid being low on the micronutrient test and vitamin D being low intracellularly, but the serum is high. We correct the oleic acid, which is part of the cell membrane, and all of a sudden intracellular vitamin D improves and serum levels maintain. How do telomeres play a factor in Alzheimer's? The thing that we have to look at with the telomeres is, of course, as we know, here's these chromosomes that we look at and how fast they are more or less degrading and being destroyed. And everybody looks at that as aging process. The point is this: a lot of the same nutrients that affect the telomere status of an individual also affect the brain tissue. Like I said, the antioxidant, but there's other nutrients besides antioxidants that may come into play. And that's something that's very important. So you can't just look at a telomere and say, oh, my telomere is good or bad. It's a good chance I'm not going to get Alzheimer's. Or there is maybe a really good chance I'm going to get Alzheimer's if your telomere is real bad. The point is, what nutrient or nutrients are affecting the telomere, and what are the similar nutrients that could affect the brain? Is there research out there to support that? And I have that happen sometimes where patients will come into me and all they have is a telomere test. And they say, here's my telomere test, what vitamin or mineral do I need? And I honestly say, I don't know. Because there's so many different things that affect the telomere. And the same thing with this, and hopefully you've seen that tonight, that you might hear out there, you might read an article tomorrow about DHA and Alzheimer's. You say, oh, that's great. And you might read another article in a couple of weeks or months or years, vitamin D and Alzheimer's. Are those researchers wrong? No, they're not wrong. Are they telling us something? Absolutely. But look at all the nutrients tonight that we talked about that have a role or have been associated with dementia or mild cognitive impairment or Alzheimer's. And that's the point, is we need to be checking all these nutrients as research continues to develop. we need to add other considerations there. But I think there's a lot tonight that you've seen that you have to start looking at. I need to, for example, if I was a clinician tonight hearing this, I'd say, I need to do that micronutrient test. I need to see if they're ApoE. I need to see if they have an abnormal MTHFR. I need to, once again, look and see if they have adequate DHA through a mega check. So there's several testing procedures available to you out there as a clinician to start to put these pieces of the puzzle together and say, we need to address this, again, for looking at possible relationships of dementia or Alzheimer's. Once again, the name of the book, for some of you that might not have caught that, is Amino Acid Chelation in Human and Animal Studies, and it's by CRC Press. It was published in 2012, and I will guarantee you that when you start reading that, you will have a total different appreciation for how sensitive the body is and how certain nutrient forms have a much higher bioavailability than the other, and it's very well referenced, and I think you'll be very pleased with it when you read that. It's not a very large book, but I can guarantee you that it will keep your interest for a long period of time, and it's very intense. So I don't know anybody that could probably read it in one sitting because it's so highly involved chemically and biochemically. But it's, once again, I think a very credible book that will give you a total different insight of what nutrients you want to provide in what form. And also, once again, knowing that you need to still test these people, because even if you use the best form of a nutrient, or the highest bioavailability form of a nutrient, you still have to know, is it still the adequate dosage to the patient? And there's no way that you can know that unless you do some objective testing, such as like the micronutrient test. So once again, I appreciate your time tonight. Hopefully that this has given you some insight to a very devastating condition that is staring us right now in the face and is increasing and will continue to increase in the next several decades unless we do something from a preventative standpoint. So have a good night, and once again, thank you again.
Thank you, Dr. Grabowski. We are out of time for any more questions. We truly appreciate your patience with us tonight. VectorCell will be announcing our February webinar in the next few weeks. Stay tuned and have a wonderful evening.